Good afternoon, everybody. This is the last of the sessions that we've had over the last 2 days, and hasn't it been a wonderful conference? Right? Absolutely. Please put your hands together for all the great organizers. And this is only the first Global Health Forum here at AUB, and it's not going to be the last. And we look forward to seeing you at the next one, and we'll find out when that will be in the not too distant future. This particular panel, the political determinants of global health, we hope will really tie in what you have heard over the last 2 days. We've heard the problems, we've heard solutions, we've heard challenges. But what I'm going to talk about today, and I'll set this up before I introduce the fantastic panel that we have today, is to really try to pull that all together. So, great. And what I'm going to talk about really briefly is a neglected vital pillar in global health. And I would suggest to you, as we think through this, as we're going through the speakers today, please think about how we don't have an option in terms of not dealing with this challenge. This is absolutely foundational, whether you were involved in maternal and child health, whether you were involved in public health strengthening, whether you're involved in infectious diseases, NCDs. No matter what you are involved in, this pillar has to be addressed, and it's not. So we know here's our targets, right? The Sustainable Development Goals, 17 goals, 169 targets. And we know that these challenges all affect us in the planet that we live in, whether it's NCDs, whether they're environmental challenges, whether they're conflict and political upheaval. All of these issues are affecting our well-being. But I would argue that there, in fact, is a common thread, a common pillar, a common foundation for global health that is being neglected. And what I'm going to show you today is what that foundational deficit is. And in fact, I would suggest how we are going to deal with it, how we can deal with it, how we need to deal with it, particularly those of us who are in academia and NGOs. If you look, and this is a slide that we pulled up with the IMF on your left, Transparency International on your right, take a look at the 10 poorest nations. If you ask yourself, what do they have in common? You can see that every single one of them are countries that are in various states of disrepair. These are where the poorest people in the world live. This is where we've had intractable poverty, intractable healthcare challenges. But all of them have failed, inadequate, or weak public institutions. It sounds boring, but think of it this way. Whether we're trying to train healthcare workers, whether we're trying to implement what we discover in terms of new drugs and vaccines, whether we're trying to be able to make a decision on water and sanitation, what do you need? You need to have effective public institutions and an effective public service that's able to implement those, right? And they not only include ministries of health, but they include other, which I would argue are more important areas in government. I call them the political determinants of health. We tend to focus right on the top. Justifiably, we're trying to figure out new vaccines, new drugs, new devices, hire more people, train more people. We're focused on that, which is essential. But even if you have those vaccines and drugs, even if you train those people, whether those people are being trained, and we heard earlier today, whether or not there's the water and sanitation, whether there's the electricity for them to do their work, you've got to be able, whether that exists, those are all political choices. And earlier today you saw Dr. Sukat's fantastic presentation where we tied in knowledge, science, and politics. Well, I'm going to talk about the last leg of that, because that aspect underpins all of what we're trying to do. Don't you find we justifiably are really focused on ministries of health, which is important, but think if you were the Minister of Health. You need money, right, to do your job. You need some engineers to be able to build good water systems for people to have access to potable water and sanitation. You've got to be able to have roads so people can get to clinics. I was meeting with the now former Minister of Public Works in Liberia just after the Ebola crisis. And he was a young, smart guy. And I asked him, I said, what's the most important thing your country needs post-Ebola? I thought he was going to say health workers. I thought he was going to say drugs. You know what he said to me? Roads. I need roads, because 70% of the time our roads are not workable because of rain. So if you're sick and you don't have a proper road, you're not going anywhere. So you're either going to be disabled, or you're going to be sicker, or you're going to be dead. So, but in order for that to happen, in order for those roads to be built, in order for those water and sanitation, in order for institutions like this to be able to be built to train people, those are political decisions. Those are political choices. So, what do you need to do that? As we heard earlier with Dr. Sukat, she made a very eloquent, showing eloquent examples from the WHO in terms of that we have the money to pay for most of what we need, right, on the health care side. But in order to do that, you've got to have a capable finance ministry and the people in the finance ministry who's going to make sure that your money is going to be able to be used to be able to deliver the public goods the people want. The cost of this, and we don't talk about this enough, and some of our speakers are going to address this today, that do you know what the loss is in terms of, well, official development assistance is about $160 billion a year. Do you know what the loss is to corruption every year? $1.5 trillion every single year. And that's a low ball. It can be up to $3 trillion. So the money that's being lost, and I point a lot of fingers at the West because that money is going somewhere. That money is being reposited in London, in Toronto, in Los Angeles, in New York, and in other tax havens. So we in the West have a lot to answer for in terms of where that money is going. And by ignoring it, we're actually allowing the theft of trillions of dollars taken from low resource settings. So how do we deal with that? We need to have effective public institutions. We need to be able to train effective public servants. We need an effective and free, and we're lucky to have on the panel today Martin Trulov, who is the Guardian's journalist here in the Middle East. But we need to have a free and open access media for truth to power to be spoken to, and for the voiceless to have their tales, their stories told for the world to see. And you've got to have an effective justice system. We ignore this. If you do not have an effective justice system, we cannot defend the rights. People cannot have their rights defended. They cannot have their rights protected. And if that does not exist, then they are left up to the depredations of individuals who are willing to abuse them in sometimes heinous ways. And we're seeing that across the world, and of course in this region, as we know. So lastly, in order for us to achieve the Sustainable Development Goals, in order for us to be able to achieve what we agreed to, we have to focus on effective public institutions, effective public service, a free and open media that's able to protect the rights of individuals and to ensure that political decisions are being made for the public, and that the public, or those who are elected, or those in power, are accountable to the public. So I'm going to stop there. So Martin, the floor is yours.
As Keith said, I cover the Middle East for the Guardian. I've done so for 13 years, and that role has been to spend as much time as I can out in the field. And there is no shortage of material to cover in this part of the world, as we all know, particularly in the last 6 or 7 years, where we've seen one catastrophe after another, whether it be in northern Iraq, across Syria, Yemen now, and elsewhere. And I think front and center to our coverage is the human condition and how to reflect that and how to report it. And central to that is the health of people that we're dealing with, whether that be community health, whether that be the health of a country. But healthcare issues are absolutely central. And through a lot of our coverage, myself and my colleagues, we are dealing with healthcare professionals, we're dealing with NGOs, we're dealing with people who have taken it upon themselves to bring primary care to people in desperate need, whether that be large numbers of internally displaced in Syria or Iraq, whether that be refugees who have made their way across borders. There are untold presentations of medical conditions. We've seen cholera, we've seen measles, we've seen waterborne epidemics, and many other things. And being upfront and personal, and just speaking to these communities as well as the practitioners that are attempting to care for them, is both raw and intimate, and it's both very real. And I do think that in covering conflict, which I tend to do, I don't like the term war correspondent. I never have. I don't understand why anybody would want to cover wars for a living. But I do report in a region where wars happen, where conflict is prevalent, and I do think that the health of displaced peoples, or even those who haven't been forced out of their homes, the community health is the most essential barometer of how the society is functioning itself. And to that end, I've been privileged enough and honoured to meet dozens upon dozens of healthcare professionals who have devoted their careers to try to put back the pieces of broken societies. We've seen it in northern Iraq after the Yazidis were forced from Mount Sinjar, or after Mosul had been taken over by ISIS. We've spent so many days in refugee camps where we've seen babies being born literally on dirt as the collective international healthcare system scrambles to catch up, or the NGO system scrambles to catch up. There always is a will. There's no doubt about that. Some of the people I've met who provide for people in desperate need have been some of the most impressive in my career. What we do come up against consistently, though, is a gap between intent and policy. Now, inevitably, there will be a lag when we have a global community scrambling to coordinate a response to something as catastrophic as, say, the ousting of several 100,000 people from northern Iraq in August 2014 that simply nobody saw coming. Within a few months, we had 400,000 to 500,000 people looking for shelter on the plains of the north in the middle of summer. Now, the international response to that was initially slow, but it did ramp up. We already had a festering crisis in Syria where the numbers were staggering then, and even more so now. Upwards of 8 million internally displaced, 6 million people across the borders. So I don't think there's been a time in the modern history of the Middle East where we've had so much going on simultaneously. And it's understandable that there has been a lag in a response. But what I'm worried about now, though, is the political dimension that we're looking at globally is one where multilateralism is very much under threat. And I think multilateral institutions, the UN, its various incarnations, WHO, World Bank, IMF, MSF, all of them, they have been front and center of the solution to the catastrophes that we've seen unfold so far. And they've done so because we've had a global order which had been anchored in rules and values. Now, what we see out in the field now is that global order, which may seem abstract and far away, whether it be in New York or whether it be in Brussels or elsewhere, the epicenters of it, the realities are that the slow unwinding that we're seeing in the global political order is very much being felt on the ground, where a lot of the aid pledges for certainly for healthcare are not being met. I heard last night that for the first time in 30 years, the ICRC is underfunded, and we're hearing similar things with MSF, and also the UN commitment, or the commitment to the UN rescue program or relief program in Syria. So all around, the global political institutions that have safeguarded vulnerable communities for so long, or vulnerable countries, seems to be under strain. And that is something that weakened states in this part of the world aren't necessarily equipped to take up the slack for. So while I admire the noble works of my friends and colleagues and the organizations that have done such an extraordinary job in very difficult circumstances in this region in the last 5 to 10 years, I do worry about their stamina. I do worry about the political will to support them going forward. And I think these are discussions that need to be had on panels such as this, but beyond this panel, I think the global multilateral system needs to understand that if it continues to be diminished or weakened or demeaned, as some global leaders are attempting to do at the moment, then that will have truly profound implications for a region that simply can't take any more shocks.
Thank you very much. Thank you very much, Martin. That was very eloquent and powerful from what you've seen for 13 years in the region. Dr. Bizri, please.
Good afternoon, everybody, and I would like to start by thanking our moderator, Keith, for being so kind to Lebanon and not mentioning my country in the first 10 most corrupt states, which I believe that Transparency International needs to revise its... well, I hope I can get it right this time. So I don't... Okay. Since the concept is political determinants of health, I would like really to quote this, which I believe is very true. Politics is nothing but medicine at large. And in order to take health issues into context, we really should put them into the political agenda. The only problem is that the empirical evidence of the effect of politics remains to be really very scarce and not very solid. Although we believe and sense it, yet we cannot really quantitate it or determine it. So most studies are observational rather than experimental. And since health is a political concept, we as politicians, we as health physicians, we need to become more politically oriented. And since we have already referred to the Ebola outbreak in West Africa, it's a good example of how political determinants shape the response to that outbreak itself. So unfortunately, lack of political will is always to be blamed for the reason why we fail. However, we as academicians, we as professionals, we have also to blame ourselves, because public health research has failed yet to deliver really good data. Sometimes we became more advocates of a certain cause rather than the true analytical perspective of the reason why this happened. Unfortunately, the primacy of the economic over social policies, which is the new liberalism which we are experiencing now, is affecting the social welfare system, and we still fall into trap between what we call charity and rights. So sometimes we believe that we're doing a philanthropic effect, yet it's the right of the citizen and the right of the community and the society. This is where we as academicians and responsible for curricula have to integrate what you call the social medicine into our curricula. However, and the social concept, the concept of social medicine has evolved. It's from the Che Guevara's revolutionary medicine, which stressed the social origins of illness and disease. Now the academic discipline is probably progressing. It's becoming more interesting. AUB has really a very good section in its curricula about social medicine, and the presence of many of our medical students here make us believe that they are interested. Yet we have to discriminate between some approaches to the social structure and social behavior related to social medicine, whether it is really we have to concentrate on the social structure as the cause of or the determinant of the social health, or whether it's the lifestyle, or probably the combination of both. So this is why the WHO framework for action in order to improve health outcome stressed on the importance of quality. So we have to have what you call quality improvement. Yet the problem with quality improvement measures, they have all been tailored towards developed societies, towards rich societies. And when we come to apply them in developing societies or the more poorer societies, we usually see that the data is sporadic, it's very poor, it's very little. Despite that, we still can achieve some successes. There is an evidence that quality improvement have achieved a lot in a resource poor setting, mainly when it's related to the I don't know if I'm working, it works fine or not, I don't know. So mainly when it's related to the emergency obstetric care, when acute child care, the primary care, which now in Lebanon, for example, is a jewel to be reckoned with in our health crown in Lebanon, the health systems improvement and the prescribing practices, which in Lebanon is unfortunately, for example, is very poor and really needs to be revisited. I'm not going to go all through the Millennium Goal, but I'm going to stress two things with achieved very well properly in Lebanon: the reduced child mortality and the maternal health. If you look at the maternal health in Lebanon, we know that since at least 14 years, and so we had achieved very good levels related to maternal health in Lebanon, since the maternal death rates, since the mortality maternal death rate is 23 per 100,000 live births, and 95% of women or more received perinatal care, and hospitals and good centers are usually the place where they deliver. So midwives probably in Lebanon now or home delivery plays a little less role. This is probably related to the fact that we are still a small country and most of the medical centers are quite accessible to us. When we go to the child health in Lebanon, and we see that infant mortality rate is low, and this is not only when it comes to infant, but under 5 years of age is also quite low. This is due to many facts, including the improved vaccination coverage that the academicians, in partnership with the government and the non-governmental organizations, as well as the UNICEF and the WHO, had a partnership together. So Lebanon successfully improved vaccination coverage, so we have very good vaccination coverage rate. We managed to contain the polio outbreak. We prevented that from accessing Lebanon, despite the fact that polio re-emerged in Iraq and Syria, and we have more than 1 million Syrian refugees residing in Lebanon. We provided vaccination to Syrian refugees as well, good coverage that resembling of the Lebanese children. And Lebanon, since declared officially in 2002 free of polio, we are maintaining every year. We are providing through the NCC, which I'm the current chair now. We have annual reports to document that what we are doing is enough to keep the country polio free. So the issue of public health and the social movement in health really is of essence if you want really as academicians to improve on the health outcomes. So public health in general relies on two main pillars: advances in biomedical sciences and improvement in administration. Yet the problem with administrative measures, yet the problem with public health, it's always sometimes it's too anxious to respond to the threat of epidemics and pandemics. Whenever we see something, we are usually try to rush and try to do something about it, which is understandable. So this is why we believe that a robust public health system increases social stability, has greater economic development, allows greater economic development, and finally can improve biosafety and biosecurity vis-a-vis preventing external disease, epidemics, or even the bioterrorism. So the risk of epidemics and what will be the role of the academia, since I'm responsible to talk about that quickly. So academia were involved in many of these epidemics. We don't have a lot of time to discuss them all. So let's start with the Leishmania outbreak, for example, in Lebanon. Lebanon never really experienced Leishmania. It's mainly a disease endemic to Syria. In 2012, when we started receiving Syrian refugees coming to Lebanon, we start seeing a significant increase in the number of cases until we really had this epidemic. This epidemic was contained with the help of academicians, of doctors practicing at AUB and other centers at the Lebanese University. Even our pathology labs were providing a free consultation, our infectious disease people, our dermatologists, and in fact, if you go to Nature Medicine, Lebanon was given in 2015 a very good example about the ability to contain such an outbreak. The same is true for measles. We know that we experience measles every 5 years. In 2013, the epidemic or the outbreak was relatively larger, more intense, probably strained by the presence of so much increased number of Syrian children. The rapid immunization campaigns, which were designed in agreement with academicians and with people in these committees that probably contained this. Now we are experiencing another new measles epidemic, and we are responding to that very quickly. The most important thing, I'm not going to bother you with this slide, but looking at the people who developed measles, we discovered that many were really developing measles at a very young age, below 1 year of age. So we went back again and decided to redesign our vaccination calendar. We reintroduced the 9 months vaccination profile, and we make the first dose of MMR and the second dose of MMR within the first year. The same is true with viral hepatitis A. We've witnessed and experienced an outbreak of hepatitis A in Lebanon, and if we go back to this outbreak, and including the red one represent the Syrian refugees in Lebanon, and the blue one are the Lebanese, you can see that we have an increase in this outbreak. We decided to introduce the vaccine because of financial reasons. The vaccine is not yet introduced, but we deserved a lot. We received a lot of help when it comes to our water system, providing good water facilities, water system, drinkable water, tappable water to the refugee areas and to many of the underprivileged area. Everybody knows about the famous garbage crisis in Lebanon. AUB, as an example, me and 3 or 4 other AUB professors were part of the task force formed by the Lebanese Minister of Health at that time, Wael Abu Faour, in order to at least contain the medical implications and the health implications of this outbreak. And you can see this famous river of garbage. And our first response was by Dr. Saliba. She's a professor of chemistry, where she really proved that the chemicals burned the atmosphere around the burned sites of garbage is full of chemical carcinogenic material. And this is the second response. This is also my group, where we have proved that there is an increase in dog bites in the street of Beirut and many other urban areas, because we know that dogs do really replicate and gather at feeding sites, and garbage was a good feeding site for these dogs. So we gave our recommendation. We were not only happy to publish this material, we gave our recommendation to the Ministry of Health, to the municipalities, and we know that we have now many breeding sites for these dogs to be domesticated, mostly in many areas now in Lebanon, with the help of some NGOs. However, we did not wait for the crisis to happen. We gave AUB gave its expert opinion about the processes to target the garbage problem in Lebanon, mainly rejecting incineration as an option, although unfortunately the legislators has passed it despite our advice. So this is an example of how we failed despite our positive input for that. Quickly, what about preventive medicine and the role of the academia? In cancer screening, colorectal cancer is important in Lebanon. It is the third most common disease. And now, in the partnership with the Public Health, Ministry of Public Health, academia, mainly from AUB and Hotel Dieu, and from some NGOs, now we have a new screening policy, which is the FIT test. It is going to be implemented soon. Now it's becoming a legislation. And these are examples of how we educated the public as academicians. These are some of our GI and surgeons colleagues talking about the disease. The same is true for breast cancer. For those of you who know Dr. Saghir, he is the head of our Center for Excellence for Breast Cancer with the First Lady and the Minister of Health. AUB research really it changed the practice in Lebanon. Vis-a-vis, for example, we have a lower incidence of breast cancer among younger females in Lebanon. So this is why our guidelines and our Ministry of Health will implement screening at 40 years instead of 50 years, as in many Western countries. Now we are talking about also some DNA changes and variations, and whether they are related to the same mutation limitations we see elsewhere. And more importantly, we have progressed further. This is data from Hammoud Medical Center, which is another university hospital, that tells us that they encourage ladies to, and they are forming what you call a lobby group in order to force the Ministry of Health and other, for example, what you call third-party payers to provide financial support to breast augmentation post-breast surgery, because this is where the ladies used to be questioning the value of surgery if they are going to lose the one or two breasts and so on. Smoking cessation, you know all Fadl Khouri, he is our AUB president. He was named the WHO World No Tobacco Day Award this year. AUB is very active, and it's not only Dr. Khouri, but it's also the tobacco control group. We have a lot of research on water pipe, because most of the research is unfortunately on cigarette, not on water pipe, and we do a lot of research, and this is directly linked with the WHO General Secretary. And finally, before I leave, the immunization practices, the NCC, which is mainly formed from academicians, from AUB, from Hôtel Dieu, from Lebanese University, from other medical schools. The National Certification Committee makes sure that polio-free activity overlooks them. They are doing well to keep Lebanon polio-free, as well as keeping up with measles and rubella elimination. And we have our NITAG, our National Expert Group, that usually provides advice for our national calendar, which is slightly changed from international calendars based on our epidemiological study. This is data from our group to show that 90% coverage can protect Lebanon from the polio entrance when we had the polio Syrian crisis. Finally, to conclude, really, I believe that partnership between the public and the private sector is important, especially in a resource-limited country such as Lebanon. The private sector is the academia, the non-governmental organization, and even some other entrepreneurs. The discipline of social medicine should be integrated in our curricula and modified as needed. Doctors are should be political advocates of what they believe they should do. Better public health research is needed, experimentally as well as observationally and epidemiologically. Improve public awareness. We have to tell the public what's their right, and it's not a philanthropy, it's a right. And finally, the primary care is the essence of any good public health system, mainly in a resource-limited country such as Lebanon. Thank you.
Thank you very much, Dr. Bizzi. That was a powerful presentation. Dr. Khalif.
Thank you. It's great to be here with you today. I'm going to be talking very briefly about these 6 topics, and if none of these are interesting for you, you can have a break. So now, I guess I don't need to really emphasize the point that health is a public good, especially when I look at the audience and the people that I've spoken to earlier. That's a pretty well-known factor. But of course, it's always good to emphasize that governments are responsible for the provision and planning of health in their populations. Citizens do have a right, have a central role also in shaping the health systems that are running at the national level, and even at smaller levels such as regional, and to a large extent we also try locally. There is, of course, the issue of health inequity, power, money, resources. We of course all know that there is large inequities in health, but of course they are also very clearly related to inequities regarding power or money or resources. There's been a lot of experience in terms of structural readjustments across various countries. We know of a lot of lessons have been learned, particularly since the 70s and 80s in Latin America, Africa, other countries and regions as well. Particularly the issue of austerity politics. It's quite interesting to see the impact both in lower middle income countries as well as high income countries. There has been some very impressive research coming out lately, which has shown that when it comes to the impact of health or of economic crises on populations, whenever we have a 1% increase in unemployment rates, we have an increase in the mortality among those younger than 5 years by 1 out of 1,000 persons. So in other words, if you want to think about it, in a country of 10 million people, that's in excess of 10,000 additional deaths in the younger in the age group that's younger than 5 years. Among adults, it's about half as much, and you can project it. That's mostly looking globally, and it varies a bit somewhat in other countries. They've also looked. Researchers have also looked in some pretty powerful and robust reviews as well, and they have tried to associate. They've looked at the impact of GDP. With GDP, an increase in GDP does not, as far as they have found in various studies that have come out over the past 3 or 4 years, an increase in GDP has not resulted in any improvement in mortality. So that's also another issue. If we really want to dig into it, it would seem obvious to someone who actually digs into what actually goes into a GDP indicator. It's a pretty bad indicator in many ways, if you really dig into it. Maybe 40 years ago and before that, it was a pretty good one. And then other factors started being also considered within the GDP. And then it also depends, you know, are we talking about the money that is going into, or the income that is going into the top 1% or top 10% or the bottom 90%? So that all matters. In some countries, we see that the top 10% versus the bottom 50%, some inequities are decreasing. But if you compare it to the top 1 or 2%, it's the opposite. It's actually widening. So even in the upper income categories, you have increasing inequities. So that is one thing. It's also quite interesting. We've seen a lot of what is happening. Sometimes things that happen in more developed countries tend to get more attention in the media. And when I think of one thing, of course, there's Greece, which is a very, very interesting example, and that's given a lot of lessons also on the austerity on the health sector there and how suicide rates have skyrocketed. And particularly if you look at calls to suicide hotlines going up by more than 20 times. Of course, there are societal taboos when it comes to, in some societies, whether people have committed suicide or not. So you don't always see it reflected in the cause of death. But that is one thing. But even looking at the UK, particularly in England, there was a Health and Social Care Act a couple of years ago in 2012, and there's been a lot of very thorough research coming out of that. It's quite impressive, and the politicians for a very long time, or most of the MPs that were pushing for these changes, were assuring citizens that this wasn't privatization of the healthcare sector, this wasn't privatization of the NHS by the back door, but practically this is what has actually happened with a lot of outsourcing and privatization. And it's of course, when it comes to politics and health systems, there are ideological issues that come in. But if you really want to look at the impact on populations, on people, regular people, when you see that you've had in excess of 40,000 deaths because of a health reform that you have done over a period of 4 years, that should be a pretty big sign that things are going wrong. They project that the Health and Social Care Act will actually end up killing, by 2020, will end up having resulted in about 150,000 excess deaths in England. So these are pretty big issues. And if you look at just briefly to talk also about the issue of corruption and conflicts of interest, more than half of the members of parliament who were actually pushing for these reforms of the NHS in the UK had shares in companies and corporations that were going to benefit from these reforms. So that's also quite an important issue to look into. There's very often conflict of interest in various sectors. It depends how you look at it. We as researchers or public health practitioners also sometimes encounter issues of conflicts of interest. But ultimately, you need to have the proper monitoring and accountability mechanisms to detect these occurrences and then have ways to deal with it. So going back to what some of my fellow speakers have mentioned, the issue of a proper functioning judicial system is a key issue. The Sustainable Development Goals are not really sustainable, but they are important. They're extremely important because they do give us a target, similar to how the MDGs worked as well. But ultimately, nothing is sustainable if you look if you exclude the idea if you include the proper externalities that are involved in this. The Earth has finite resources. The resources on this planet are not infinite. When we talk about growth and development, we need to really see what do we actually mean by these. Of course, we should work on improving our health and environment, jobs for people, social interventions, and all of that sort of thing. But at the same time, the way we go about this shouldn't necessarily be tied to increased profit, particularly when we think about the increasing inequity. So I think I'll leave the rest of the sustainable bit to the climate change last talk. But when we talk about public and private sector roles, there's this issue of privatization of healthcare. The evidence that privatization of healthcare, or that the private sector functions more efficiently than the public sector, is absolutely zero. Since, Kenneth Arrow over 50 years ago showed this, that the health market does not function like a normal market does. There are various market failures involved. And we try to go about this. We try to address this using various tools, which are important to work on and innovate. There's this issue of public-private partnership, which I believe is very important. Nevertheless, we should think about this in terms of a tool. It's not an end goal by itself. To a large extent, the last Sustainable Development Goal has to some extent, framed it as a goal in itself, but it is not. Of course, in most countries, the public sector is not capable to reach everyone. In these kinds of contexts, you have to look at it and analyze how cost-effective is it going to be for the population if you were to partner. There are huge opportunities. The health ministry in Lebanon, we have a long experience of partnership with the private sector. But when we say private sector, it also matters whether we're talking about the private for-profit or private not-for-profit. Are we talking about academia? Are we talking about financial ventures that want to come in for a couple of years and extract as much resources as they can, minimizing their own risk? And increasing or decreasing outcomes for patients, for example. So even within this issue of the private sector, we need to work more on defining who do we mean by the private sector. So overall, private-public partnerships do have a potential. The evidence isn't clear at all whether or not it is beneficial or not. It's, of course, context-specific. So you need to look at your own context and analyze and see if and how you should approach it. And finally, climate change. So this is certainly not my specialty topic, climate change, but we have all heard of climate change a lot over the past couple of years. So earlier this year, I decided to dig into it a bit more, and there's an intergovernmental panel on climate change, and they have done regular reports on this, and it's getting more and more attention. I've had the chance to talk to some climate change scientists, some of whom are authors in the IPCC report, which a lot of governments also rely on. However, the IPCC report, usually the estimates that are mentioned, like an increase in sea level rise of about 1.5 to 2 meters by the end of the 21st century, are the most conservative estimates in this report. There are less conservative estimates in this report. And besides that, overall, the report tends to be far too conservative, even by some of its authors. So there are of course, limitations to how much they can talk about this. But I will just let some of these slides basically this is all from NASA, and over here we can see climate change. When you have specialists sometimes talking about it, it sounds too complex, and it is in many ways, but we need a better way to have a broad and simplified way of explaining this so people can really start thinking about what it involves. Overall, it's not too complex. If you dig into the details, it is. And it's going to be, and it is the major, the defining factor or issue that we're living in today. And this is the defining moment. And that's, these are words of the UN Secretary General. So this is carbon dioxide increasing over the past 400,000 years in waves and going down again. Carbon dioxide functions like a mirror. In some ways, a one-way mirror. It traps the radiation and heat from the sun in our atmosphere, on our planet. And over here, we see the level in 1950. And over here, we have the level today, the current level, which is about 400 or 410 parts per million. We see carbon dioxide increasing since 2006, quite steadily. We see that since 1880, we have now resulted, and this is getting far steeper, in an increased temperature by 1 degree Celsius. The original estimate, or basically there is a lot of evidence that this will increase by with an additional 2 or 3 degrees Celsius before the end of the 21st century. And that has huge implications. I mean, as humans, maybe we won't feel much, or we cannot imagine much that this has a major impact, but it has a huge impact on our ecosystems. This is how much ice Antarctica is losing in the south in terms of gigatons of ice, and this is Greenland. Last year was the first year that Greenland turned into slush ice, so that's one step away from it all melting. And when Antarctica all melts, when all the ice melts on the planet, we will be 65 meters below water at the moment. Or in other words, the sea level will be 65 meters above where we are. It's a direct relation, of course, with the carbon dioxide that's in the atmosphere. And this is in the Arctic as well, and how little, this is by month since 1979, how little ice we are having. And this is a short video showing in the Arctic, changes since 1979, and it varies in the different seasons, winter and summer. That's the variation you will find. But let's quickly see. Oh, not playing. Oh, there it goes. So note that over here it is reaching the various borders over here. We've got Russia and Denmark and Iceland and Greenland and North Canada over here. It's going a bit slower, but of course, increasing sea level. Right now, the carbon dioxide at 410 parts per million, it will result in a 10-meter rise in the sea level. And with the current technology, there is nothing we can do about this. There is nothing. The only issue is the rate of change. Nobody really knows the rate that the sea level will increase. The IPCC report says 1.5 to 2 meters. Perhaps more realistic estimates are 3 to 5 meters. Nobody really knows. So that is one major factor. This isn't really playing well, so I'm going to move on to the last slide or two. And this is sea level variation, and the relation is not linear. It happens with at certain tipping points things increase. And why is all of this not getting much attention? Is because most of these changes are happening in places where people are not present in the far extremes. And finally, there's the issue of methane. You have the melting permafrost. Methane alone within there are several times more methane in the permafrost, which is the decaying or not yet decayed animal and plant matter under the ice and in frozen soil. Once this melts, if these plants and animals are decaying in air, it results in carbon dioxide. If it decays underwater, it results in methane. Methane levels are currently skyrocketing, and if we have a methane burp, as scientists call it, from one of the lakes in Siberia, or currently as what is happening over here, these methane bubbles that are forming under various lakes in North Canada, in Siberia, in the Arctic, then methane is 30 times more potent than CO2 in to our atmosphere. And we will have a 2 to 3 degree Celsius rise in global temperature within a space of about 4 or 5 years. The main issue that we should be worried about is famine, because our crops, particularly wheat, maize, and rice, do depend on a narrow range of temperatures. So that is a major issue that we should all be planning for as well. And I'll leave the rest. Thank you.
Thank you, Dr. Khalifa. A great way to end your topic on the IPCC panel report, which is being largely politically ignored at our great peril. Dr. Tam, please. And do get your questions ready. I'm not going to ask a question because time is getting short, but you have a superb panel of people here, so you'll be up next, just forewarned.
Good afternoon, and thank you to all the panelists today for their very interesting presentations, as well as all the other distinguished panelists from the conference. It's been a very interesting and eye-opening experience. Today I will discuss some challenges to healthcare response in a refugee hosting country like Lebanon, based on my own personal field experiences working in the MSF South Beirut project. And just to give you a little bit of the context and where I work, our project, we provide a diverse range of services for vulnerable populations. And vulnerable populations includes Syrian refugees, as well as Palestinian refugees, vulnerable Lebanese, disabled populations, migrant workers, and so forth. And also children and youth and elderly. We provide non-communicable disease primary care for adults and children. We do childhood vaccinations. We provide care for pregnant women as well as normal vaginal deliveries, including emergency referral services. We do comprehensive sexual and reproductive health, including family planning, health promotion, advocacy. We do have integrated mental health in all our services. We have social work services available as well. And am I missing anything? Anyways, we do a very we have a very integrated concept of care, and I'm very proud of that, working with MSF. As many of you know, MSF is traditionally an emergency humanitarian health organization that usually works in conflict and low-resource settings without an existing healthcare infrastructure, or not a very strong one. In Lebanon, in contrast, MSF is working in a middle-income country with a functioning and quite high-quality healthcare system, which is currently being overwhelmed by the Syrian crisis. Here, emergency care for refugees in public hospitals is subsidized by UNHCR, but since the cost of care is relatively expensive in this setting and available funding is insufficient, as Martin alluded to, care is only partially subsidized in order to ensure more coverage of more refugees and vulnerable populations. In addition, limited human resources, services, medical supplies can contribute to social tensions between the actual host communities and the refugees and other vulnerable populations. Another challenge is the requirement for health INGOs and NGOs to extensively cooperate and collaborate with the existing healthcare institutions and the system's rules and regulations, while navigating complicated bureaucracies and barriers and restrictions to programming, something that we don't usually encounter when we work in very low resource settings. Another challenge is trying to address the needs of refugees and vulnerable populations in an urban setting. In Beirut, our beneficiaries are scattered throughout the city and even outside the city, and sometimes even across borders. this disbursement makes it difficult to assess their needs, to access them, and to eventually tailor interventions for them. Follow-up and compliance is a big concern. This is in contrast to working in a closed setting like a refugee camp, for example, Satari refugee camp in Jordan, where humanitarian assistance is thought to be actually quite appropriate because they are working in a population that's more homogeneous and enclosed. In the context of the Syria crisis, both refugees and other vulnerable populations come from very diverse socioeconomic, religious, and cultural backgrounds. Because our beneficiaries, we see they're not homogeneous, it is very difficult, as I mentioned earlier, to tailor programs, community outreach, and advocacy. One example is that we discovered through focus group discussions and interviews that there really isn't a sense of a refugee community that we thought there was. And this is because the Syrian refugees come from diverse backgrounds, religiously and culturally, from all different regions in Syria. Therefore, there's a much stronger focus on the individual family unit because they don't trust anyone outside of the family and they're just trying to survive in this setting. This focus on family caused us to alter and change our approaches in family planning advocacy. Sorry, too loud. Usually, is that, it's okay like this? Okay. Usually we focus our efforts on empowering women, for example, to take their own decisions about when they want to have their family, how many children they want to have, and the family spacing from a sexual and reproductive health right lens. However, by doing so, we undermine the strength of, it's not working now? Okay. Sorry. Hello? Is it working? So by focusing on empowering women from a rights perspective, we undermine the strength and security of the family unit bond. And we find that the women actually prioritize this bond, and they don't want to alienate their husbands, even though they know that they do have the right to make these decisions. So that's something that was interesting for us to know because it changes how we approach our family planning advocacy. Another interesting challenge that we face is the expectations of the Syrian refugees in relation to healthcare. They are used to free and high quality care in Syria prior to the crisis and are quite educated and medicalized. For example, they're used to receiving lots of medications for every ailment and getting regular ultrasounds in pregnancies and seeing doctors regularly. Given the fact that they have a good baseline medical knowledge, for example, pregnant women know they should see medical professionals during their pregnancy, and they know they should be delivering in hospitals with a skilled birth attendant. This is a paradigm shift for many MSF staff, including myself, who have worked in other low-resource settings, such as African countries, where healthcare workers have to convince women to actually seek medical care during their pregnancy and deliver with a skilled birth attendant to avoid maternal death and newborn death. Here we need to work on balancing the expectations of our populations with their actual needs and within the realm of limited resources. So we need to actually do more research and put more focus on how do we identify the truly most vulnerable women needing our urgent support versus those who seek care from us because they are free when they might be able to afford it elsewhere. So this conference is an excellent opportunity for stakeholders and academia to work together to find solutions to, for example, the challenges I discussed. We've learned from our experiences here in Beirut that we cannot apply our traditional cookie-cutter model that we usually do for providing sexual and reproductive health services in low-resource settings. Therefore, MSF recently had to change its goal and strategy from only providing free services to those in need to being a catalyst for change as well. And this we can achieve by advocating for the midwifery-led model of care for safe pregnancy and delivery. The evidence from many low and high-income countries show that the midwifery model is safe and cost-effective. That is why MSF employs this model in its sexual and reproductive health projects around the world. We have been using this model here in Beirut since a few years ago, and we have helped vulnerable women safely deliver over 5,000 babies in the past few years. There's not very much evidence of this model being used in the region, and given its cost effectiveness, we feel that there is potential for this model to work in Lebanon and the whole region. This could help alleviate the pressure and cost of hosting refugees for host countries' healthcare systems. Over the past year, through successful cooperation and ongoing collaboration with the Ministry of Public Health and the Rafiq Hariri University Hospital, we have opened a midwifery-led birthing center next to the Rafiq Hariri University Hospital just a few months ago. Our goal, in addition to continuing offering free sexual and reproductive health services to vulnerable populations, is to now empower many more midwives through a training program in collaboration with the midwifery schools and the Order of Midwives. Therefore, through mentoring, capacity building, and task shifting, we are offering a sustainable, cost-effective solution to meeting the growing and challenging needs of refugees and vulnerable populations. That is at the same time contributing to strengthening the overall healthcare system. Thank you.
Thank you, Dr. Tam, and thank you very much for the work you and MSF are doing. We'll take 3 questions. Questions? Yes, please.
Okay, my first question is, how can the international community empower local citizens in corrupt LMICs to demand quality service? And what incentive does the international community have to fight corruption in specific countries? And finally, who or what can regulate the international agencies' interventions?
One more question? Anybody else? Yep, and then we'll open it up to whoever wishes to answer it.
I have an ethical question. So since we know that the housing conditions for some of the refugees, whether they're in informal settlements or, because they're not supposed to be called camps here in Lebanon, I guess, are very, let's say, not optimal. When you have women that want to become pregnant and want to have children, how do you deal with that, knowing ethically that probably the child isn't going to have great housing, maybe not have access to a good education? Or do you think that the NGOs are doing enough that you can say, okay, they have the right to have more children? I think this is an issue. It's been an issue everywhere when you have the inequalities. So I'm just wondering, as a provider and even as a government, how do you deal with that ethical balance?
Thank you very much. So please, we'll start in the opposite direction and work our way this way. If you wanted to respond to any of the questions, Dr. Khalifi.
Regarding my thoughts regarding what the international community could do, fundamentally, there are major issues that have to be tackled regarding prioritizing the social sphere rather than prioritizing the economic sphere. There has to be a balance, both issues. I think sharing best practices to a large extent is very important, but we can see that there is also many instances of corruption, at least in the healthcare sector. There's a lot of examples from various countries, some large-scale examples from U.S. Medicare, Medicaid. We're talking hundreds of millions of dollars, $300 million in one instance. It's been estimated in the NHS system about 15 to 20% of the cost is actually going towards corruption or or practices of that sort, non-transparent practices. There's the issue of exclusions as well, how certain contracts in the are excluded from commentary or involvement of technical experts, so the persons who are actually involved in the delivery of healthcare. So there are various issues, I think. It's a very important topic. Fundamentally, it would have to, you need the political structure of the country to be responsive to the citizens' needs and rights and expectations. And here, I think, in another sense, climate change is, in some ways, I didn't mean to depress so many of you with that, but it also presents an opportunity. Because of its massive impacts, it will provide opportunities for people to revise and reprioritize certain issues. Fundamentally, there's nothing holy about a certain level of GDP that's spent on healthcare. It's citizens who should be having the role in deciding that, and then addressing these issues of corruption. And I think my fellow panelists will also have something perhaps to add on that.
Wonderful. Dr. Tam, please.
In terms of the first question you asked about accountability, I think that's what it was about. From my experience, not just with MSF, but in general, the work we do, we need to be more accountable to our beneficiaries and our stakeholders. And I think that involves maybe more looking at what we do, not after we've implemented something, but looking at it throughout the whole implementation process so that we can continuously reevaluate what we're doing and making sure we're reaching the goals that we're trying to reach, or targeting the population that we're trying to, or doing the advocacy we're trying to do. Because oftentimes I see programs with good intentions starting, and then 2 or 3 years or 5 years later, they reevaluate the program goals, the log frame, the indicators, and then we find that we don't reach them. And then we'd be like, why? But after 5 years, we have lost a lot of funding and time and effort into this. So what we can do is work more on process evaluation, impact evaluation during the entire programming process, and that's a relatively new area of research, but I think that would be helpful in making sure that the organizations are more accountable for the donor money and for the time of the workers involved. In terms of the ethical balance question, it's a very interesting question. When you actually work with the women and you actually ask them about what their beliefs are and their attitudes are towards having families and family planning, you need to look at it in the context they're coming from. And for the Syrian refugees, they come from a context where they've lost children in the war. They're scared to lose more children, and what makes them secure is to have that family. And again, I emphasize that the family unit is very important. So they have done a study, I think AUB in collaboration with the MOPH looked at family planning attitudes, and actually women are feeling they are in control of choosing the number of kids they want and when they have it, and even in relation to discussing it with their partners, they're aligned. So we have to consider that aspect as well, that it's their choice and their decision in this time, in this context, and then as organizations, as institutions like Ministry of Public Health or other agencies, we need to help support them in making this decision, because ultimately it's their life. And we're here to try to improve that and help them, and not trying to control it.
Thank you very much, Dr. Tam. Dr. Bizri.
I'll try to be brief and, in fact, answer your question by raising some other questions. First of all, about the empowerment of citizens. I know that there are a lot of agencies, and some of them may be unfortunately politically motivated, trying to have some sort of workshops or activities or programs about citizen empowerment. The only problem with the international community and Lebanon is that the international community in Lebanon has become really a photocopy of the Lebanese politics, which means that they usually, and I'm sure you can comment on that, many of them do duplicate the same thing. For example, you see that there is a fund given to a certain administration. I have two other capacities than being university professor. I used to be the mayor and the president of a region, and I'm the head of one of the largest primary care units in the south of Lebanon. So I know that the international community is willing to spend money even for the same project, which has also been spent by a different group somewhere else. So this is why there is some sort of lack of trust between the community in general and some of these international funding organizations. When it comes to the issue of the refugees, the Syrian refugees do resemble a very peculiar group of refugees, because many of them had roots in Lebanon, in fact, before. Many of them are accustomed to the Lebanese way of life and so on. And more importantly, many of them, when they moved into urban areas, as mentioned before, and not into tented settlements, most of them. And they decided to move as families and groups. So the whole clan sometimes moved. For example, one of the issues we raised was that the whole clan from a certain part of Hama came and moved to that part of, let's say, of my city, Saida, at that time. And this is where we... On the other hand, this is when there is a very interesting issue that most of them were settled in poor areas. And this is why they become also a threat to the Lebanese social matrix. They become a threat to the Lebanese social matrix because they are not only competing for medical help and social aid, but sometimes they are competing for jobs. They are very skilled people. They are extremely skilled, and they are willing to do anything for almost very cheap labor, which is an excellent labor, to give them the credit for that.
Thank you, Dr. Bisri.
I'll just speak briefly to the issue of empowerment. I think we touched on these issues yesterday, and the empowerment of citizens through through social media, through having a voice, through having platforms that they didn't have a generation ago, has to be more broadly a good thing. There are many caveats to that, as we've been observing, and that is that how easily these voices can be co-opted and pushed into certain directions, how easy the discourse can be disrupted or distorted. That said, everybody is trying to find a formula to deal with how giving so many people such an active voice and almost an equal voice in many ways, how was that going to benefit the body politic in the long run? How was that going to lead to genuine empowerment rather than making groups of people subject to being politicized? Everybody's struggling with it, Twitter, Facebook, and all these platforms. But I think that the faith in the long run is that giving citizens a voice, irrespective of the ease to which these platforms can be co-opted or politicized, will work out down the track. It's just going to take a while.
I think that's an excellent way to end this session with a challenge to all of us to utilize our agency to be able to use our knowledge and the access we have to knowledge to advance issues and to improve the social determinants of health, particularly for those who are least privileged in our world. So will you join me, please, ladies and gentlemen, to thank our wonderful panel. Thank you all for being here today.